Right, so we are live. Thank you everyone for joining us for yet again another one of Chiromo Hospital Group's live discussions that we hold every Wednesday on our Facebook, LinkedIn, and YouTube platform. So we would like to thank everyone who's watching this conversation from wherever you are. You are most welcome. So today we will be talking about a very interesting and much needed topic, one on understanding psychiatry. And the goal of this conversation is to shed more light and break the myths and misconceptions around what psychiatry is about. And with us, we have a very beautiful panel. We have Gadoni Mbogwa, who is going to be moderating this conversation today. Gadoni Mbogwa is a clinical psychologist and also the head of digital relations at Chiromo Hospital Group, and the clinical psychology head at AAR Hospital. Thank you so much, Gadoni, for joining us. We also have Joseph Abuga, who is a very active mental health champion. And in addition to that, I'd also give, when the time comes, Joseph the time to introduce himself further. On the panel, we also have Ian Kipangat, who is also a hospital psychologist at Chiromo Hospital Group, and is going to also share his information and insight on this topic. Joining us later on will be Dr. Nyamute, who is a psychiatrist, who will also give us a lot of information on what psychiatry is about. She has just joined us right now. Thank you so much, Dr. Nyamute, for joining us. And in addition to that, finally, we will be having Odiambo David, who is a pharmacist. So this is a well-rounded panel ready to work on breaking the stigma around what psychiatry is and understanding it better. All in all, creating information and the right information around matters mental health. At this point, I'd like to welcome the moderator and hand it over to her so that she can take charge of the conversation. Gadoni Mbogwa, over to you.
Thank you so much, Pendo Ochola, for that really wonderful and great introduction. I'm really excited to be here today. I hope I'm clear. Hi, panelists. And I can't wait to have this conversation today. I think most of the most frequently asked questions around psychiatry is what we'll be delving in that today. And I can't wait just to demystify what this is all about and probably help one or two people out there. Dr. Nyamute, you joined us a little bit late, but let me give you the opportunity to just introduce yourself. Yeah, in case there's something specific you'd like to say about yourself. And then I'll do that with Ian and Joseph as well.
There's nothing specific. Anyway, I'm Dr. Linda Nyamute. I'm a consultant psychiatrist at Isiolo County. Yes, for those of you who didn't know, Isiolo is a county. It's a county by itself, and it's not in Marsabit or Lodwa, as I get told. But yes, psychiatrist in it, and I'm also an active mental health advocate, and I love spaces where we talk about things mental health. I'm also the founder of Mental Sphere, which is an online platform where we create awareness on mental health. So yes, this is me on a daily basis, and I'm glad to be here. Thanks, Gazani.
Thank you so much, Dr. Nyamute. I'm actually, I'm in the category of the people who've just learned that Isiolo is a county. I didn't know. So thank you.
No.
Thank you for that. As we are having this conversation, you are a psychiatrist. What is it that made you choose psychiatry? What determined you to go into that line of psychiatry?
Okay, yeah, there are many reasons. At the end of the day, I wouldn't say like there's one particular reason, but for when you're in medical school, we're usually exposed to all rotations. You go to obstetrics, you go to pediatrics, you go to surgery and all that. So I think when we went to psychiatry and we went to Madare, I know this is strange, but when we got to Madare, I was like, yes, I feel like this is what I want to do. But that was undergrad, of course. You get exposed to more rotations, and I think when I went for my internship, it just solidified I did not want to do anything that was, I don't want to say this in a bad light, but yes, like emergency and requires to me to be awake every night and interfere with my sleep, and then I didn't want anything stressful. And also one thing probably you've noticed, I talk a lot and like give people advice, but I'm also a good listener. So yes, they're listening, they're talking, yes, both.
Thank you, Dr. Nyamute, for that. I could see you looking for the politically correct words to use on, but I hear you. Yeah, and there we have it. This is actually really a perfect panel to have this kind of a conversation. So I'm really glad that you're here, and I really want to thank you for that. Ian has been one of the serving psychologists at Chiromo Hospital Group. Just allow me to ask you the same question as Dr. Nyamute, like why psychology? What drew you to that side?
Thank you, Gagoni. What made me choose to do psychology? Growing up, I saw many people who are living with mental health condition and a lot of stigma surrounding them, being segregated even by their own family. So when I learned that mental health conditions can be treated, I developed that passion to learn more about it and help people who are living with it, and be among the people who are working on demystifying the stigma surrounding mental health. So it's one field I'm really passionate about.
Wow. And last but not least on this panel, we have Mr. Joseph Abuga. Mr. Joseph Abuga is a psychiatric nurse. This is why I'm just loving this panel today. Who is a psychiatric nurse, maybe, and what made you choose to do that? Please unmute. Thank you.
Am I audible?
Yes.
Okay. Good afternoon, my fellow panel members. As you have heard, I'm Joseph Abuga. I'm a psychiatric nurse here at Chiromo. Basically, what drove me to psychiatry is from the previous experiences. I've ever heard in psychiatry, there's this saying that if you're not affected, then you're infected with mental health in one way or another. Unfortunately for me, one of my close relatives was a mental health patient, and it took a long time before people came and understood what is mental health, and there was no one who could be standing up for my own close family members to instigate this mental health calamity. So until then, I was a pediatric nurse. So it was not until I was personally infected with this mental health issue, then I decided to further in, and I developed more urge to be a mental health nurse so that I can help others in broad to overcome this problem which has been cropping into other people's lives, both knowingly or unknowingly. I believe with time we shall have to diversify more as we get into the program. Thank you.
Thank you for that. Let's just get right into it. I see time is really chasing us. So one of the questions that will usually come out, and I really want the people who are joining this conversation or will find this conversation later to come out of this space fully loaded, at least with information. So I'll start with Dr. Nyamute. Who is a psychiatrist? What do they do? What's the difference between a psychiatrist and a psychologist? Yeah.
Yes, Gadoni, I agree with you. That is a very commonly asked question. A psychiatrist, just to try and make it into very simple language, a psychiatrist is a mental health professional with medical background, meaning that they have done medicine as their primary degree, or rather their basic degree, their undergraduate degree. So they go to medicine and then they come and specialize in psychiatry. So this is a person who will also be mostly dealing with medications, the prescription of the patient. But psychiatrists and psychologists work hand in hand. So the psychologist now will come in to do the therapy, which is equally very important at times. Depending on the disorder or depending on the condition the person has, sometimes even therapy takes precedence over the medication. So at the end of the day, both professionals are very important in mental health, and psychologists mostly do therapy.
And before I move on to engage Ian, so a cardiologist is basically trying to look at the heart, heart matters of the patient. What is a psychiatrist really focusing on, and what kind of illnesses as well? Maybe if you could give us like 2 or 3 examples.
Okay, so psychiatrists will be focusing on the mind. So there's the physical brain, where the neurologists come. We also work hand in hand with the neurologists. So then they work on the physical brain. If you have things like tumors, or cancers, or growths in your brain, or bleeds in your brain, or an infection in your brain, then they work on the physical aspect. As we deal now on the functionality of it, now how you think, how you feel, how you behave, how you function within the community around you, how you socialize, how you go to work, go to school, basically what you do on a day-to-day basis. And of course, when those are interfered, they can, in one way or another, disrupt your day-to-day functioning. So things to do with problem, we said the way you think, the way you feel, the way you behave. So disorders like the most common mental disorder a lot of us know about is depression. So depression, of course, now will also interfere with how you think. These are people who have probably a negative perception of the world because their thoughts are predominantly negative. How they feel sad all the time. How they behave, they maybe want to be socially withdrawn. For someone with bipolar, of course, now they'll be having the exact opposite symptoms. They'll be feeling they're on top of the world, extremely excited. Some have very grandiose sort of thinking. By grandiose, I mean they feel overly confident beyond their abilities. Some will say they've been sent by God, they are Jesus some way, yeah. And how they feel, how they feel happy all the time, they're overly talkative. How they behave, they're overly familiar with everyone. So the disorders are quite many. We have those that affect our mood. We have those that affect our perception, what we see, what we hear, what we feel. So that's schizophrenia and the psychotic disorders. We have those that now addiction, which is a lot of people know about. Everyone probably knows someone who has an addiction problem. We also have disorders in children, which we usually try to avoid talking about, but it's there. Yeah, so the disorders are plenty, but probably those are the most common. Including suicide, which we know of as well.
Yeah, thank you so much, Dr. Nyamute. Fantastic. Ian, you are a psychologist. And who exactly is a psychologist? And while you're telling us that, there are also other terms like counselor, clinical psychologist, counseling psychology, therapist, all these terms that are out there. So for somebody who is catching this conversation online, how would they be able to know, who those people are or what's the difference?
Okay, a psychologist is someone who went to college and they study behavior. A clinical psychologist deals more with the mental health disorders, like um, bipolar mood disorder, doing therapy for people living with bipolar mood disorder, people living with psychosis, like Dr. Yamuche said, people with the disorders that affect the perception. So a clinical psychologist deal with the mental disorders. A counselor does more of behavioral, but it's almost the same thing. We all do therapy. So a psychologist is someone who went to school and they studied behavior. And we work hand in hand with the psychiatrist. We offer therapy and the psychiatrist prescribes medication. Also, a clinical psychologist does assessments or evaluation just to compare notes with the psychiatrist to make a diagnosis. Yes.
Thank you, Ian, for that. Before I go to Joseph and before I go to Care, let me just get back to Dr. Nyamute, because you said that psychiatrists work with psychologists. And I'm just wondering, for anybody out there, how would they know when to go to a psychiatrist and when to go to a psychologist?
That's an interesting question. For me, my answer to that is always, it doesn't matter. Wherever you start, you'll still, if you end up at the psychiatrist's office and what you require is more therapy, we'll refer you to the psychologist. If you end up at the psychologist's office and they feel like you may be requiring medication or psychiatric evaluation first before they can proceed, they will refer you to the psychiatrist. At the end of the day, it will be a bit difficult to tell someone if you see that you are having severe symptoms. How does someone know what severe is? For us who are in the field, we can tell this is severe and this is mild. But for someone who that is the one case they know, how do they know this is mild, severe, or moderate? So for me, at the end of the day, my advice is usually just take a step, seek help. Wherever you land, you'll still be offered to the right office.
Thank you for that. It's okay not to be okay, and also, in line with the initiative that we are trying to push out there, to funguke, just like Dr. Nyamute has said, speak out. It's okay to seek help, and really, it doesn't matter where you start. The most important thing is you've started, and if indeed you're dealing with a professional, be it a psychiatrist or a psychologist, then they are going to be able to refer you appropriately. Should you be at a psychiatrist and they think you also need to have a therapeutic conversation, then they will refer you there. If you're seeing a psychologist, a professional psychologist, they are not going to go ahead to try and describe medication, on behalf of a psychiatrist, or even just give you a diagnosis. Actually, if you're watching this conversation, a psychologist cannot give you a diagnosis. The only people who can be able to do that is a psychiatrist. And that's also from another long conversation. And a diagnosis is it's not a light thing. So you're not going to have one session and you live there, with a diagnosis. So it's from a long process of a lot of information that is gathered way beyond just that patient only, family as well, meeting a criteria, assessments done. So it's really, it's quite a process. And even the psychologist would refer you to a psychiatrist for that collaborative process to work well for the benefit of the patient. I was going to go to Joseph, but he's dropped off, I'm happy to be joined by David Odiambo. How are you, David Odiambo? Please tell us about yourself and what you do.
Hi, Gadoni. How are you?
I'm
Hope
fine,
you guys
thank
can
you.
hear me. Pleasure.
Yes.
It's a pleasure to be here, and apologies for joining you guys late. So I'm Odiambo David, that's by my name. I'm a pharmacist by profession, currently working with Novartis, a regulatory affairs associate, and I run a program on mental health, that is agriculture, health, and social innovation. Just a disclaimer, whatever kind of insight I'm sharing would be affiliated to agriculture work, but not Novartis. So that is good to clarify so that somebody doesn't say I'm speaking on behalf of Novartis. No. But I'll share my insights and support the conversation in how we can improve access to mental health care services and ensure we have a healthy society.
You've actually come at the right time of this conversation. We were just trying to figure out who sees a psychologist, who sees a psychiatrist. You know how that does that conversation go. But before I ask you a question, one of the other questions that is usually asked, and just allow me to ask Ian this: do people actually need to see both? Does an individual need to see both a psychologist and a psychiatrist, or can they see one only?
Is that to me or to Ian?
To Ian.
You can walk in and see either psychiatrist or a psychologist. Let's say, for example, you walk in and you see a psychologist, and the problem you are presenting with needs further evaluation. They'll refer you to a psychiatrist. If you walk in to a psychiatrist and they evaluate you and they feel like you need to see a psychologist for therapy, then they can refer you to a psychologist. So it's a multidisciplinary approach. You can see either a psychiatrist or a psychologist. Then if there's need for referral, you're going to be referred to one.
I hear you, and I see Dr. Nyamute is quite ready. Let me just throw in something else just for clarity, because this is a very, very pertinent part of conversations with patients and people in the public. So if I have a psychologist, why do I need to see a psychiatrist to give me medication? And we'll talk about medication again. Or if I have been seeing I go and see my psychiatrist, and my psychiatrist gives me medication monthly. Why do I need to go and see a psychologist? So I'm approaching this question from: do you need both? Should you see both? Do you have to see both or not? Dr. Nyamute, welcome.
Yes, I understand where the question is coming from. Just a minute. Sorry. As I was saying, sometimes when you come to the psychiatrist, depending on the psychologist, depending on what illness you have, the severity of the illness, you come up with a treatment plan or a management plan together with your psychiatrist. I'll assume psychiatrist, because if you need medication, you definitely need to see a psychiatrist for that. Sometimes for some patients, in a lot of cases, when we are dealing with things like maybe severe depression or someone who has had a post-traumatic stress disorder, and they're having quite significant symptoms affecting their life, this is not someone you'll want to live without therapy. In as much as they need medication, they'll still need therapy. So sometimes we have, and it's not uncommon, we have spaces where we're incorporating both therapy and medication. So we ask them to see maybe the psychiatrist after every 1 month, but every week they still continue with their therapy sessions. It's usually interesting because sometimes the patients cut off seeing the psychiatrist because they're like, I've been seeing my therapist, or they stop seeing the therapist because like I get my therapy session from my psychiatrist. But you see, no one can take the other's role. We all do different things in this space. The other thing, maybe the only time you may see one is maybe when there are some psychiatrists who specialize also in clinical psychology. So in such cases, you have one-stop shop, something like that. Yeah.
Right. Thank you for clarifying that. And I like to use the analogy. If you go to a hospital and you're sick and you've been admitted in that hospital and you're told you have to do tests. So even though the hospital is capable of running all those tests, they will have to call in for consult. Yeah. If they were like mamas, like heart, there's something wrong, then they'll call in a cardiologist, or they'll call in a neurologist, they'll call in the nutritionist, because you need to have a conversation about intake, the food. And this is just to emphasize on Dr. Nyamute's point of, we cannot take each other's place. However, there are some special scenarios where you will find one person who's done both, and in that case you can benefit both from therapy and the psychiatric part of it from one person. So there is that. Joseph, at where do psychiatric nurses come in? And as you're telling us that, I know there are a lot of people who don't know we have psychiatric nurses and what they do and where they work. I see David is agreeing with me very well. So at what point do psychiatric nurses come into this conversation of mental health?
So just to pick in from where my colleagues, Dr. Nyamute and Ian have left us, this is a multidisciplinary. This is like a three-legged stool where, say, the psychologists, the psychiatrists, and the nurses, they team together for the well-being of the patient. Now, after a patient has seen the psychiatrist, he or she has been prescribed some medication, the psychiatrist will hand over the patient to the psychiatric nurse. So most of the time, like 90-80% of the time, the patient will be spending the time, if he is admitted in a hospital, with the nurse, with the psychiatric nurse. So the psychiatric nurse will be able to implement what the psychiatrist has prescribed for him, and also as to implement what the psychologist has suggested, that this is a kind of a therapy is good for you, this is what is best for you. So a psychiatric nurse will be like taking the overall care of the patient and reporting the feedback both back to the psychologist, like this patient, for the better part of the day, this is how the patient was, this is how he was behaving, or how she was doing. She did this, what I suggest needs to be done to him, and as well as at times there are some times where the patient cannot fully express he or herself to the psychologist or to the psychiatrist, and at that time, as a nurse, you can observe something that is interesting, which you report back to the psychologist or the psychiatrist, like this patient has been changing, or his or her behavior is not that normal. So we are like an interlink between the patient and the clinic, or the psychologists, as well as the psychiatrists and other team, like even the nutritionist, where will come and tell him, like, this patient has something like bulimia nervosa, where like she feeds and then she goes and throws up, So we are like a link in between the patient, because we spend more time with the patients than the others do, because at night we are the one who like watch how long do they sleep, how is their sleep pattern, are they having any kind of nightmares, are they sleepwalking, are they how is their sleep, and generally monitoring their all round mood evaluations, and then reporting back effectively to the respective psychologists or the psychiatrists as well. Thank
Yes.
you.
Thank you so much, Joseph, for clarifying that in very, very well. We just actually celebrated Nurses Week for the first time in the world, and I'm really honored to have you in this panel. Nurses actually really do a lot of work where patient care is concerned. And truly, truly, we can't do without them, literally, or we can't do without each other. So even before you go and see your patient, you want the nurse to actually be able to tell you how has that patient been, because they also spend a lot of they actually spend more time with the patient than any other practitioner out there, be it mental health or physical health. So we do appreciate the work, and thank you for clarifying that for us. Now that you brought in the conversation of medication, and I'm so glad that we have a pharmacist in this panel. But before I go to you, David, let me ask Dr. Nyamute. The question is, when I see a psychiatrist, will I have to be put on medication? Yeah, because then the myth, or rather the fear or the anxiety out there is, I don't want to see a psychiatrist. They're just going to put me on this medication and everybody will think I'm crazy or not well. So just tell us about that.
At the end of the day, there'll be an assessment done. You come, you talk to your psychiatrist. These are the kind of difficulties I'm going through. These are challenges. These are the symptoms I have. I'm having difficulty sleeping. I'm having difficulty maybe eating, focusing, or maybe I'm having unusual experiences where I hear voices or I hear people calling my name and I can't see them. So you explain to your psychiatrist what you're going through. From you come up with a diagnosis. Now, even so, with the diagnosis, we have different diagnoses have different severity forms. So now, depending on how severe it is or what kind of difficulties you're going through, that now will necessitate the need or the lack of medication. Now, here's the catchy bit, because I know that is usually a very common line that a lot of people usually have, or rather, it propagates stigma and prevents people seeking help. And the reason why a lot of people will come to the psychiatrist's office and get medication is because a lot of people wait until it's too late, until it's been there for very long, it's severe, it's like your last resort, like the one that you've been pushed against the wall for. So what happens at that time, by the time you're coming, chances are it's been so severe. But for people who seek help early and maybe have milder symptoms, and have mild symptoms or mild episodes, they may or may not get treatment. Sometimes someone comes, maybe, for example, they have lost a loved one maybe a week ago or something, and they're feeling a certain type of way. That's not someone we'd medicate, because we don't expect it to be a stone with no feelings and no reactions. But so that's someone you probably send for therapy to get some psychological assistance, guidance and all, how to handle the grief. But now when it becomes prolonged and it's now affecting other aspects of their life, sleep, for example, how they eat, how they interact with other people, then to that point, again, it's a case-by-case basis. They may require treatment. But again, not everyone who comes in to a psychiatrist's office gets medication. The only reason is because people wait until it's too late to enter the psychiatrist's office. By the time they get in, most of the time the disease has progressed, the illness has progressed further.
I am so glad that I'm having this conversation today. This is a really stellar lineup of panelists today, and thank you, Daktari, for highlighting that, because just to reiterate a bit, not every patient who enters a psychiatric office will come out with a prescription or carrying medication. Yeah, the difference also comes in at what point do you go. And because of very many other beliefs like witchcraft and trying very many other things before you get to that decision, sometimes in terms of severity, things have gone a bit too far by the time you're going to see that psychiatrist. So it might seem like in most cases you're getting medication, but also it's at what point did you come into treatment? Yeah, I'm glad Ian is here. Ian, because I know Dr. Nyamuta said you will see a psychiatrist once in a month, you will see a psychologist weekly. And one of the things out there is also that medication has like some side effects. So if a patient comes to you, maybe as a psychologist, you either notice they're having side effects or maybe they complain to you. No, let me not use the word complain, just raise a concern that probably they're adding too much weight. What else have I heard? They're dosing. They're dosing. Maybe what would be your role then there?
Like I mentioned before, we work as a multidisciplinary team. So when let's say, for example, a patient saw a psychiatrist a week ago and the appointment for therapy is this week, and there is a concern that they're having side effects, I will go ahead and inform the psychiatrist, update the psychiatrist on the progress of the patient. And then if they need to see the patient, then maybe the patient can be contacted by the psychiatrist office to come in for review. So where I come in as a psychologist is by updating the psychiatrist on the progress.
I don't know if it's my network, but thank you for highlighting that, because even the clients, the patients, they are human beings, and sometimes they will be going through experiences, or you could be going through experiences out there, and you're wondering, is this supposed to be normal? Am I supposed to be feeling this way? And really, I just want to challenge you to always to feel free to act. At the end of the day, you know best how you're feeling. Yeah. Even better than whoever who is seated on the other side of the table. So it is okay to actually verbalize, and then from verbalizing that, then you can actually get a confirmation to yes, you will feel like this for a certain period of time, or no, I hear you, so that something can be done about it. And if you don't have an appointment with your psychiatrist at that point, then this is also a conversation that you can also have there with a psychologist, and a good psychologist will ensure that they help follow that up with the psychiatrist. Where beneficence is concerned, we're just trying to do what is best for that patient. David, thank you, welcome back. Yeah, I just want to engage you a little bit, and are there some medications that are better than others? And what determines side effects? I mean, now that you are in that space of medication.
That's an interesting one. So I wouldn't say there are medications that are better than others. Based on what contribution Dr. Nyamute highlighted, in terms of treatment of a patient, you diagnose, that is the first thing. What condition are we treating? Then once you've diagnosed the patient and that actually diagnosis has been made, then we look at the criticality and the severity of the condition. They are mild that you'd consider having psychotherapy, just talk therapy and all that. But then we move to the point where some people have severe conditions, or the diagnosis is a critical one, then they need to be on medication. Then the question is, what medication are they being put on? That would be based on the discretion of the pharmacist and the physician, that is the psychiatrist or neurologist, depending on where they're being taken care of. But in terms of the medication that would be better or not, the only challenge we have is we all know the products that are currently you can buy medicine from anywhere and everywhere. And oftentimes, one of the things that we have to acknowledge is for psychotherapeutic medications, the medicine that are being used in treatment of mental health conditions, these are controlled drugs, because beyond just managing conditions for those people who are unwell, there are people who are actually misusing them in terms of their trade, in terms of their own operations. So in that case, then they need to be limited in terms of access, who is going to access them, at what point, and all that. And that is one thing that we need to be critical about. The other bit is there is an influx because there's high demand for them, both in the black market, people who are using them for the wrong reasons, and also those patients who need them, who might not be able at times to afford some of the medicines. Somebody would import a substandard or a fake product, and they would tell you this is what's going to treat you. So is it effective? Definitely not. But at the end of the day, it has already been sold. Then the other connotation that normally people have is most of the mental health medication, the psychotropics and all that, these medicines, most of them have not been developed into the generics. So you find the original products that were developed by the initial innovator companies are the ones that are still available in the market. So the cost for such would be generally higher because they have to recoup the amount of money they invested in that kind of research to develop products. Therefore, then the generics which would be cheaper. If somebody buys a generic, they would say it's cheap, yes. So is it really associated with the quality or not quality? Because somebody comes to pharmacy and tells me, by the way, David, I want these medicines, the original one, not the generic. Why? Because they think the generic one is fake. But in reality, the generic is not fake. It is the same medicine, but that person did not invest in the research. So it's still effective. So the question is, at what point do we choose which medicine to use and how do we use it? And that is now where the clinical specialists, that is the psychiatrist, the neurologist, and the pharmacist, come into the table, as Dr. Nyamuta was talking about, a treatment plan. What medicines are we going to use to treat this patient? What is the criteria? Are they able to afford? Because even before you prescribe a medication and dispense it, you need to see, is the patient able to buy it? Because if you're prescribing a medicine they will not buy, then of what use is it? So those are the kind of things, but I wouldn't say there's anything that is, or any medicine that is superior to the other.
Yeah. Thank you. Wow. Thank you so much. We really needed you in that panel. I know the question of medication is, it's quite a big one, and it cuts across a lot because of what is found out there in the shelves. There is also the part of where we as individuals, do not really understand. Like you've said, we've not done enough research to be able to know what we want or what are the available options. And then there's also a cost implication. So sometimes somebody might still be prescribed a medicine, but the advice is this cheaper version of it that might not be, as effective. So it still goes back to the drawing board, to the psychiatrist, having that conversation, verbalizing your needs, your fears, and having a completely authentic conversation without fear of whatever it is, be it stigma, be it discrimination, be it fear of looking like you don't know. You would rather not know, but get all the information rather than go and ask that kind of information from somebody else. There is also sometimes, I would say, peer pressure around people outside there, not putting in mind the question of also drug interaction. So somebody will say that, I was feeling anxious, so I tried this pill. Maybe you can try that pill. And you go ahead and try it out, not really knowing that how does that really interact with you as an individual with other medications. So I think this is just that we ought to be more careful. But because we have Dr. Nyamuta here, I would also like to hear her thoughts on that conversation. Are there medications that are better than others? What determines side effects where drugs are concerned? And we are about to wind up, but yes. Please unmute. Thank you.
Something I think David has covered most of that. The only thing is for us, when it comes to our prescriptions, okay, let me speak for myself. When it comes to the prescription, normally we try to not restrict the patient to a particular brand, and that's because we don't know the the pocket of this person. You know, what we are interested in is the molecule that is required to go and work for the patient. Yes. So we usually want, if it's a patient who requires maybe an antidepressant, we just write the chemical name as it is, and then I think that is a word David usually has to pick from there, because now they have to decide, fine, this is the molecule you've been written for, these are the brands I have, this is the original brand, and these are other brands. And I think at the end of the day, now that becomes a question of a lot of the time it's usually a cost implications, because you have to remember these are patients who will be on this medication. It's not like how you go and buy an antibiotic, which is a 5-day course treatment, and it stops there. For a lot of psychiatric patients, or mental health patients rather, it's usually medication that's used for a very long time. For some, a lifetime, for those who may need it. So you have to consider this is a person, they're spending, there's a tablet, I'll not mention which one, it's a tablet that goes for about 900 shillings a tablet. So you calculate that they need that every day, some even twice a day. So you can imagine that every day for a month, that's about 27,000. Calculate that for a year, that's about 300,000 or thereabout. Calculate that for 5 years. This person has already spent so much money on medication. Want them, if they have no insurance, it becomes another strain. So for us, we usually don't like to restrict on the, okay, personally, I usually don't like to restrict on the brand. You can suggest a brand, but at the end of the day, what we're interested in is the molecule that will work.
Maybe
Wow, thank you so much.
Ronnie.
Yes, please go ahead, David.
That's on the last bit when you're talking about the side effects and all that. We have to acknowledge that one key thing that as professionals we are cognizant of and we need to address is the fact that when we are treating our patients and you're taking care of them, we need to be open and share as much information as they would need. And that is where now it comes to the point of telling them, why are they using that medicine? How are they supposed to be using it? And there's something that you mentioned about drug interactions, there's drug food interactions, and any other things. And because one key thing that I feel from a professional perspective, beyond being a pharmacist, I'm David, I'm a human being, I'm a member of the society. And the very challenges that these members of the community, the patients who come to me for guidance and for support as a professional, they go through the same challenges that I go through on a daily basis. Maybe somebody's going out with friends, the kind of food they eat, the drugs they use. Let's, for example, somebody partakes of alcohol. Is there a probability that that alcohol will have an interaction with the medicine? If I don't actually engage that patient to discuss with them such kind of issues, they would be like, oh, normally, what is the normal narrative for us as doctors or healthcare providers? I would tell you, stop alcohol, stop smoking. It's everything that we feel you should not take, we tell you not to. But the reality is, why are they being still produced if we are not supposed to be using them? It means people are using them, and we have to be cognizant of that. Then now when engaging patients, we need to tell them objectively, you should reduce of your alcohol intake or even stop it altogether for the period that you're using this medicine. This is the reason for this particular guidance, and therefore it makes it easier for the patients to adopt it. Two, oftentimes when let's say, for example, a medicine has been prescribed and I'm supposed to be dispensing it. This patient already had been recommended another medicine by a friend who used it at one point in time. And therefore they've been using it. But because there's a new prescription, I'll dispense what I've been given. But because the other medicine they were using at home, which was recommended by a friend, has been working, this person will now be on two classes of medicine, or even a double dose of the same medicine. So are we helping that patient, or are we actually killing them? And that is where now that kind of collaborative engagement, beyond collaboration within the healthcare practice, we have psychologists, psychiatrists, pharmacists, neurologists, critical care nurses, and psychiatric nurses. We are all part of the team. We understand the technicalities of healthcare service delivery. Then now let's move it from our own collaboration of knowing what is good for the patient from our vantage point to engaging the patient as a human being to see how is their life moving around, how do we make it better for them, and how do we continue the journey in helping them better. And I think that would help actually solve most of the challenges that we're seeing in terms of medicine use, failure to use the medicine. For example, even when you talk about lack of adherence and compliance. Oh, I took this medicine, I was not able to sleep overnight, and therefore I decided to stop it. But it's not that the medicine did not work. It worked, but that was a side effect that as a pharmacist, probably I failed to tell the patient. So then the patient stopped using it. Who is going to be blamed? Maybe the psychiatric nurse who actually was administered the medicine. The next time the patient didn't take it. But we're transferring the blame to the wrong person for not doing what we needed to do at the start. And those are some of the things that we just need to look into as well. Thank you.
Wow, thank you so much. We are tackling the conversation, Understanding Psychiatry 101, and I'm joined by a fantastic lineup of panelists. We are about to end this conversation, but there are some few questions that have come on our Facebook page, and I want to ask one to Ian. It will be displayed there. Let me just read exactly what it says. This is from a lady called Esther Maina. Hi, Esther. He says, does it mean a clinical psychologist can prescribe? Actually, it was to Dr. Nyamute. But yeah, Ian, tell us, can a clinical psychologist prescribe?
A clinical psychologist cannot prescribe medication. Prescriptions are done by the psychiatrist. And this is because a psychiatrist has done an undergraduate in medicine before specializing in psychiatry.
All right. Thank you, Ian, for that. And also the model we use, because in the US, I know clinical psychologists can prescribe, but not in the UK. Another question is, will I be on meds forever? Will I be on medication forever? Yeah, Dr. Nyamute, will I be on medication forever?
That's also a very common question you get. At the end of the day, there's no blanket answer to that. What happens is we get a diagnosis. Depending on your diagnosis, depending on the severity, depending on how you respond to medication, depending how many relapses you'll have, depending on your social support. There's so many things that will depend, or rather determine your improvement, your clinical, your improvement of symptoms and everything. So all that will be put into consideration before we decide, or rather to determine who will be on medication long term, who will be on medication forever. For example, a patient who comes to our office and has, let's say, mild to moderate depression, and for whatever reason they require medication, this is not a patient who will be treated for very long unless they have other episodes, so they keep having relapses, or they have very poor response to treatment. So such things may influence the person being on treatment much longer. Also, if they take drugs and alcohol, which may reduce the efficacy of, or rather the functioning, or rather the response to medication. So, but now someone, for example, who's had let's say schizophrenia, which is a disorder of perception, or bipolar, this is their 6th, 7th relapse, or they've been unwell for the past 4-5 years, and they also take drugs, or the marijuana, and smoke 2 packets of cigarettes a day. This is a patient who you have a lot of work to do, and also therapeutic work to do. When they're taking drugs and simultaneously with medication, chances of response are also very low. So at the end of the day, when they have relapses again, it's like you're starting from scratch. Sometimes you're even starting, not even from scratch, like you're starting from a negative, from where you were the last time. So there's a lot that is considered before we can say that someone will be on treatment for a lifetime, someone will be on treatment for a year or so. Yes. But one thing to note is mental health treatment for the better part of it usually is a bit longer than other treatments that you'd get, or rather prescriptions that you'd get from the doctor. One important thing, and just sorry, I know I've digressed from the question. But one important thing is to never stop medication without informing your doctor, because that usually a straight ticket to relapse for very many patients. Not everyone again, but for very many patients, is really a ticket to relapse.
Wow, you've had that for yourself. In fact, I'm not going to add any remarks on top of that. And as we wind down the conversation, Ian, how is therapy vital in the recovery of patients? Actually, before I go to Ian, allow me to engage Joseph, because Joseph is in the team or that literally just administers the medication when a patient is admitted. And I'm wondering, Joseph, what if a patient says they don't want to take the medication? What happens? And also touch on if a patient is anxious, because we know the myths that are out there. These medications will make you slow. These medications will make you worse. How do you help ease a patient into knowing and understanding that this is part of their treatment, and even though it might not feel very good initially, it will feel better? How do you help ease individuals at that that point when it feels like they're not understanding?
Thank you for that question. In our topic today, this is a common occurrence. It is we encounter it more often, like on a daily basis. We try to explain these analogies to the same patients, the same time, day in, day out, until that time he or she can come into it. But first, what we normally do is we make sure, like when the patient has some insight or has some insight to be able to know what kind of a disease he or she is suffering from, we try and psychoeducate the patient about the drug that he's taking. And this is where my psychologist team will come in and try to reason with him or her, like, because of this and this, like this behavior, you'll have to take this medication according to the psychiatrist who had prescribed it to you. And getting that info, the psychiatrist will have already told the patient, like, you'll be on this medication, and it will help you to take this or like wear off this kind of such of symptoms. Like, for example, if the patient was having nightmares, lack of sleep, the doctor will prescribe that this medication will be taking only at night for 1 week, and then it will help you with your sleep. So with that kind of information, and then we'll proceed to the psychologist, Ian, who will help him on how to initiate some sleeping habits, on how to train the patient on how to develop some good sleeping habits. So with that regards, we'll come in as nurses to administer that medication effectively and clear off any kind of let's say the hearsay. But another major issue that has been cropping up for this
yes, Joseph, or is it me?
Yeah, it's me.
Maybe one of the panelists can help. Is it me, or it's on Joseph's side?
We were hearing him well.
Yeah, I was. Yeah.
So,
what I was explaining, like there are some medications that we normally administer forcefully to patients who are like in acute cases, like who are those are maniac patients, who are those schizophrenic patients. And then for them, we normally tell them that you will have to take this medication for at least like 2 to 3 weeks. And that's where we do like directly observed treatment. And then this is the minimum period where the patient will start feeling the side effects, the proper yani the medicative value of the medicine in him. So like he will not be asking you like this drug, am I taking it for how long? I cannot see it's helping me. But continuous encouraging the patient and assuring the patient that this drug, of course, it will help you. That gives the patient some hope that eventually something gonna be done, and it will help the patient like take the adhere to the medication for a longer period. Like once like the patient has the idea like I have to take this medication for at least maybe a month or so.
I think we lost him.
Joseph, I hope we'll get you back, but we are really running out of time, and I want to keep to my promise to have this conversation to 1 hour. I believe that also this is not a conversation that we can just be able to address, in the 1 hour. And hold this conversation again, and there's something that was not addressed today, please feel free to send us those questions, and then we'll send it to our panelists, and we can see if we can do another session of just to continue with this. So please, without further ado, just allow me to welcome David, followed by Dr. Nyamute, followed by Ian, to give us just their last words, their parting shots.
Okay, thank you so much. I hope you guys can hear me well.
Yes.
Perfect, thank you. So my last statement would be, as much as we know there's a growing burden of mental health, there's something that you can do wherever you are, for yourself, for someone closer to you, including taking them to a hospital when they need that help. Do that little thing that needs to make a difference in somebody's health in terms of their mental well-being. If you can do it, that would be the best thing that you can contribute to. And I think we'll continue the conversation as we move forward. Thank you.
Thank you so much, David. Daktari, karibu sana.
I think it's very important to remember that at the end of the day, where you start off, psychiatrist, psychologist office, doesn't really matter, in my opinion. For me, what I feel matters more is you have taken the right step to speak out and taken the right step in the right direction. You'll be led to the right space. And if you have, I think there's one thing a lot of people forget. Any question you have, any concerns you have, whether it's about your medication, whether it's how long you'll be on treatment, whether it's whether or not you need therapy, whether it's a social factor that is ongoing, just bring those questions out at your psychiatrist's office. It's not limited to here's your diagnosis, take the prescription and go home. I think we moved out of that space a long time ago, where I'm the doctor, here's the prescription, take it as I say, 2 tablets in the morning. Right now, ask your doctor as many questions as you want. Let them have a conversation with you. These are the side effects of the drug that you'll have. You still need therapy on top of this. This is how we do therapy. This is how many times you'll be coming. This is how we foresee, or this is rather how we hope your treatment will go. This is how we hope on this medication for. However, it's not cast on stone. It may be longer, it may be shorter, and all that. I mean, just have that conversation with your doctor. Do not shy off. A lot of patients shy off from asking questions. We moved away from that era, and yes, we embrace more. Having more conversation, more awareness. I think it will increase more adherence and better results overall.
Absolutely. Thank you so much. Ian, parting shot.
My parting shot will be, there's no one who is immune to mental health condition. It affects everyone, either age, gender, or whatever you do in the society. And mental health is just like physical health. Just like when you feel you're having a headache and you go and see a doctor. It's the same with mental health.
Mm.
So they are manageable. When you feel you're in distress, feel free to reach out. There's no shame in seeking help. Thank you.
Okay, thank you so much. I really did enjoy hosting you. Thank you so much for your time, Dr. Nyamute. Thank you so much, David Odiambo and Ian Kiplagat and Joseph Abuga in absentia. This is a Chiromo Hospital Group live panel conversation happening every Wednesday between 3 and 4 p.m. Join us on Monday on our Twitter streets as we do another conversation on Mindful Mondays. And please do not shy away from bringing in any of the questions that you have, even after you find this video is done. And just my last quote of the day is something that I really use. If you get tired, learn to rest, not to quit. If you get tired, learn to rest, not to quit. So give yourself some grace and rest. Kwaherini.
Bye bye, everyone. Thank you.